So our next speaker really almost needs no introduction whatsoever in this area, as well as on a national front. Dr. Jeff Henderson has actually, he said I didn't need to read his whole bio. It is in the program book, and he has just done wonderful, amazing things, not just in this region, but also on a national level, and his speaking and dedication to helping put research in places that it can have the most impact, in doing so in the most impactful way possible to actually help with health is extremely inspiring to all that listen to him. And so with that, and again, please look at Dr. Henderson's bio in there, but we're just very grateful that he's going to be presenting today. His presentation is entitled Journeys Along the Good Red Road, Intersections of Culture, Science, Policy, and Health Inequities in American Indians. So please help me welcome Dr. Henderson.
Lila umpituaste mitaku yepi, Jeff Henderson na wawokia imachiapalo. Good afternoon, my relatives. My name is Jeff Henderson. My Lakota name, which as a Lakota person, we are encouraged to share our Lakota name in gatherings such as this. I told you is Wawokia, which means the one who helps. And now, not all tribal people can share their traditional names with audiences like this. So just because I and Deb Tobacco have shared our Lakota names with you, don't assume that all tribal people are free to do that, because they're not. I am Uhenumpa Lakota from the Pretty Weasel Tioshpaye on the Cheyenne River Sioux Reservation. Although I was not born or raised on the reservation, my mother was a 1960 graduate of Cheyenne Eagle Butte Boarding School, the very first graduating class after we were forced away from Old Cheyenne Agency after they'd flooded the Missouri River and created what we know today as Lake Oahe. This displaced most of my relatives and saw the tribe forfeit 110,000 acres of its richest, most productive river bottom lands. Many people, many elders even still today can express the great sorrow and the pain that they suffered after those actions were taking place, and after they were forced up from their, by all accounts, beautiful Old Cheyenne Agency setting. If you are a scuba diver, you could go down to about 50 feet now at the site of the Old Cheyenne Agency and still see standing today the old hospital, the old boarding school, the old tribal headquarters, homes that were in that community. None of that was taken down before the land was flooded, and still exists today. I'd like to have us quickly range over a few of the health issues that we know we're confronted with. We don't need to dwell on this for very long, but it'll help set the stage for what I can present. I'd mostly like to speak about the ways in which the Black Hills Center for American Indian Health engages with tribal communities, especially new tribal partners, over research projects, and how more recently we've made very, very determined and explicit steps to move away from a deficit-based perspective on issues to a strength or asset-based perspective. And a concrete example of what that looks like. It's important to acknowledge our many, many tribal partners that we have had, ranging from Alaska Native tribal corporations to our relatives down in Pima, Maricopa region in Arizona, and some of our very great friends and colleagues in Australia and New Zealand and Canada. We've done quite a bit of work and spent a lot of time in particularly the province of Alberta. We've been fortunate to receive quite a bit of funding from the National Institutes of Health, also the Centers for Disease Control and Prevention, many other partners, and particularly my wife, who joins with me at the center, Patricia Nez Henderson, and our wonderful staff. We thank the Collaborative Research Center for American Indian Health and the folks at Sanford and the conference organizers for inviting us here today. This is a picture of a beautiful pine-covered rocky ridge on the Pine Ridge Indian Reservation. Previous speakers here at this conference have shared with you the long history of notable differences in health. This is despite the fact that there's been a big transition, the epidemiologic transition that's taken place around 1950 or 1960, and that is that the primary causes of disease transitioned away from infectious diseases primarily to chronic diseases. And ever since the time of first contact, when, incidentally, all the missionaries, the traders, the trappers, anyone who came in contact with us in the 17th century, no matter what tribal groups they encountered, universally described the splendid health and physical stature of native men and women at that time. It wouldn't be long, though, and the diseases that these early visitors to the New World, as it were, brought with them, namely smallpox, typhus, typhoid, yellow fever, tuberculosis, smallpox, would literally decimate our people. How would you have liked to be a Southeast tribal member, let's say Creek, living in the 17th century, when in 1630, as you ranged throughout your traditional territory, 95 out of every 100 people you encountered were members of your own tribe, were tribal members. Only 50 years later, barely more than 2 generations later, in 1680, now, you made that same journey around your lands, and you were only 5 of 100 people that were in the Southeast at that time, due to your decimation by infectious diseases, as well as the great influx of whites and slaves into the Southeast. What a topsy-turvy time to live if in that region. And of course, that story would be played out all in tribal communities all over North America. And it's important to remember, too, our relatives in Central and South America. In fact, someone said it's as if, so for a long time we've been observed to have a pretty poor health status, both when infectious diseases were the primary things that we died from, and now, since it's chronic diseases like diabetes, cancer, cardiovascular disease, it's almost as if we have some genetic tendencies toward health disparities or health inequities. Of course, that's silly to think that way. We don't have any genetic tendencies toward embracing a life filled with inequities and health disparities. We know here in the state of South Dakota that beginning in about 1880 all the way until 1960, all prominent lending institutions in this state, including many banks here in Rapid City, took a red magic marker and redlined all 9 reservations in this state and forbade there being any capital lending in these lands. And it's not just the tribes in South Dakota, but it's the tribes in most states were redlined. Rapid City would not exist today without a robust history and benefit from capital lending. Almost no new buildings, no new business could be formed today without that. How do you put a monetary value on living in a region which has had almost 100 years of a complete lack of access to capital and capital lending? What would we reasonably agree upon as a monetary value to place on that? Add to that dispossession of land. I'll venture to guess that the price tag reaches well into the trillions of dollars. Hundreds of trillions of dollars. So let's put this in some perspective. So that when we look out across our communities and see what we would consider to be the troublesome, the bad things that are affecting us today, they really have nothing to do with there not being enough doctors or enough nurses or enough hospitals or enough clinics or well enough trained healthcare providers or enough or advanced enough or up-to-date medical equipment, a CAT scanner or an MRI. Truly, nearly everything that we can see that we could all agree needs changing, should be changed, ought to be changed, needs to be addressed, has nothing to do with the healthcare system. It's not because of the healthcare system that our health status has become what it is today. So, what can we do? So, we get a $750,000 grant. Half of those proceeds go to support personnel costs for the grant. Maybe we're able to spend half of that award in the communities, have the community benefit from half of the $750,000. And so often we, at the end, we come out of the other end with no deeper insight in or seeing that we've moved the mark at all. Well, my goodness, it could be a $5 million study with $2.5 million going to the communities. But when it's going against the tens or hundreds of trillions of dollars of economic inequity that we have been subject to purposely as a matter of policy. Talk about policy's ability to change not only the health of a population, but the whole trajectory of a population. I agree that we need to get up to speed as tribal people on how to wield the policy tool, because it has sure been wielded against us. So, I list here, and you've heard previous, the leading rates of this, leading rates of that. What I'd really like to focus on for this presentation, though, is to say that there are a lot of great things happening in our communities. There are a lot of strengths that our people still have today. There are a lot of assets in our communities, and there's ever more growing assets in our communities, such as community financial development institutes. The Lakota Funds on Pine Ridge and the Four Bands Community Development Fund on Cheyenne River are two good examples. I'm going to skip to this. Okay, so I urge us to shift our perspective away from a deficit-based perspective to a strength-based perspective with respect to research with our people. Instead of researching why alcohol dependence is so high in our people, how might we turn that around 180 degrees to look at it from maybe not alcohol dependence, but to engage with a strength-based perspective? I've come to call this the blank sheet of white copy paper approach. Here's how this works, and here's an example of it. 3 years ago, in March of 2012, the Manitoba Assembly of First Nations invited me up to Winnipeg to share some of our experiences and talk a little bit, especially about diabetes. And I said, yes, I'll be happy to do that. Please just cover my travel costs. I don't expect or need or even want an honorarium. But what I do want is I will stay a day later after the conclusion of this conference if you will set up a meeting with me with the 7 Dakota nations who are in southwestern Saskatchewan, in Saskatchewan. They said, okay, we can do that. And they did. And so the day after this First Nations conference ended, it was freezing cold, and got in a car real early and drove 70 minutes east and went to this tiny little health clinic on the Dakota Teepee Reserve. If you're from the powwow world and have been for very long, you know Dakota Teepee and the wonderful drum groups. I have many cassette tapes from Dakota Teepee, their famous drum group from there. So there I was. We went into the conference room of their tiny little health center on their 1 square kilometer postage stamp size reserve. And there were 7 people around the table, 1 from each of the 7 Dakota communities. And I grabbed a juice, and there was some pastries there. I got a pastry, and I sat down, and I waited, and after a couple minutes, one of the elders who was there kind of rustled in his chair and said, what are we all doing here anyway? What's going on? No introductions had been made. There's no obvious agenda, no slide projector set up or nothing. I looked at this grandfather, and I reached into my briefcase, and I pulled out a perfect blank white sheet of copy paper. And with some drama, I lifted it up high, and I gently placed it in the center of the table. And I said, "Grandfather," I said, "this is what we're here for." He looked at that sheet of paper. I said, "You see, I haven't come here with any goal, with anything I want to talk about. You see, it's for us to decide what it is we want to talk about. It could be anything." And grandfather, I said, if at the end of our 4 hours together, this was a 4-hour planned meeting, I have taken so many notes on this sheet of paper that nothing else could fit on that sheet of paper, we would have had a very good meeting. If, on the other hand, at the end of our meeting, I pick up a still perfectly blank white sheet of copy paper, we still would have had a really good meeting. And so the acknowledgement went around the room. Folks eased up, and then in order from eldest to youngest, they went around the table. And of course, what immediately emerged was a description of culture loss, of loss of language, of the effects of colonization. And in the 2 previous times that I had used this blank white sheet approach with other tribal groups, if you get a group of us together with absolutely no parameters around what it is we're supposed to talk about, we're quickly going to get right to the point. Culture loss, language loss, colonization. And like the 2 previous times that this had happened, as I was hearing this, it's just going to happen. But what can you do? What could I do? Those issues are like the 900-pound gorilla. And so I just provided for the space for folks to share this. But critically then, so as an example of how you can key on things to get a strength-based or asset-based perspective on things, the final speaker of the final band counselor was a young man, younger than me. He was sitting immediately to my right on the end of this rectangular table. He said, well, my aunties and uncles have said it all, really. But about this language situation, he said, my uncle, and he pointed to the grandfather, he said, on my uncle's reserve, 70 to 75% of them still speak their Dakota language. On my aunt's reserve over there, it's 55 to 60%. On my cousin's reserve over there, it's 45 to 50 or so. Even on my other auntie's reserve over here, it's 35 or 40%. But you know what he said? He slammed his hand down on the table for good effect. On this pitiful reserve, it's just 5 to 10% of us can still speak our Dakota language. Yeah, you hear, if you've had conversations with traditional people and tribal people over language and loss of language, it's pretty emotional. All his aunties and uncles and cousins and I were all solemnly shaking our heads. But then he did something that no one had ever done before. He slams his hand on the table again. Bam! He says, and you know what's even worse? I thought to myself, what? Wow. We have beautiful singing drum groups on this. We have a long legacy of drum groups from Dakota Teepee. And I said, yeah, you do. Yes, you do. He says today, we have 2 major powwows each year, and our drum groups are there, and the songs are still beautiful, and the songs are still primarily word-based songs. But if you go up to speak to a drum group that has just finished that song and you ask them what that song is about that they just finished singing, they won't be able to tell you. As soon as he said that, the light bulb just went on in my head. Just a classic cartoonish light bulb goes on. I said, of course. He said, I said, you're right. Absolutely you're right. I've danced all across the United States and Canada as a traditional dancer. I've been at powwows where I've seen drum groups get their drum taken away from them for starting to sing a woman's song when it's a man's song they're supposed to be singing, or vice versa. I've seen drum groups get stopped right in the middle of their song for not doing it appropriately. So the drum groups I've sang with, we've had some of that. A cardinal rule of a drum group leader is that none of your drum group members ought to be able to sing a song that you cannot adequately interpret to know what it is about. But obviously that's an unwritten rule that is ignored a lot of times. I said, this is a perfect example. We can do something about this. We know it critically. You've unearthed a perfect intervention opportunity. We know what to do. We know what needs to be done. We need no one else to help us. We can do this ourselves. Well, the opportunity to work with the Dakota tribes in Saskatchewan had some practical limits, the first of which is that I'm not eligible to secure any grant funding in Canada for such a project, and there were other practical matters too that prevented me from following up or being able to follow up that idea with them. But I brought it back home and talked about it with some of our relatives at Pine Ridge and Cheyenne River in a couple things. So first of all, we said, well, how prevalent do we think this is, this non-socially conversant Lakota singer-drummer phenomenon? We spent about a month. We asked all drum group leaders and other folks and stuff too, and we estimate that describes 80 to 85% of Lakota drummers and singers today. And if it describes that many of our drummers and singers today, just imagine what it must mean for drummers and singers of the remainder of the 564 or 66 federally recognized tribes that still have a traditional singing and drumming culture. And that's just North America. So I was explaining this phenomenon to one of my colleagues who's Jewish, and he said, this is exactly what happens in our culture with the bar mitzvah ceremony. In the bar mitzvah ceremony, the young initiate has about a 10-minute long recitation that they have to do in Hebrew. And he said, anymore, our kids just committed to rote memorization, just enough to get through that. They get the ceremony completed, but they don't understand. They've just memorized how to say that 10-minute long recitation without really understanding what it means. Couldn't even then pick out any of the words to use in a sentence. I said, yeah, so this is the issue worldwide one can appreciate. So we worked with linguists at Oglala Lakota College and an all Lakota 20-person project team to develop an intervention to intervene within the drum group structure with non-socially conversant Lakota drummers and singers and deliver a 12-month, fairly brief, targeted intervention that keys on the words that they already have committed to memory and can enunciate and pronunciate fine in singing. You could visualize this as lift those words up out of those songs and have them begin to use them in a socially conversant way. Introduce the proper conjunctions and verb forms and stuff that you need to drape around them, but get them to be able to use what they now have committed to memory outside of singing, socially conversant. Tremendous enthusiasm for this project. A lot of there's a lot of language revitalization efforts going on in our communities now. We have total immersion, early Head Start. We have mandatory Lakota language being taught in our high schools. We've got college-level Lakota language being taught in our tribal colleges. But somehow this cadre of drummers and singers, ranging in age from preteen to middle-aged, aren't the subject of any of those other Lakota language, are often not the subject of these other efforts. We think in research in language acquisition and bilingualism supports the fact that bilingual speakers do better than monolingual speakers. They do better on standardized tests. They do better in math, science, and technological testing and assessments. There's enough data to suggest that bilingual speakers have higher lifetime wages and salary earnings, and there's I can't, I'm not an expert in linguistics, but it's not even an emerging field. There's a lot of evidence that this is the case. So we think that if we can turn these now non-socially conversant drummers and singers to be socially conversant at a level somewhere between Lakota 3 and 4 on a five-level language scale, that we should be able to see positive life-promoting outcomes among them. They should feel better about themselves. They should feel better about others. They should be less likely to abuse substances. There's a range of outcomes that we think should be promoted, life-promoting with this. So this is a concrete example of how we could, how we treaded down that unfortunate historical path, and we may have been left to just leave it at that, but a foothold was introduced in that conversation by this young man, this young band counselor. The asset to be built upon is that we have traditional drummers and singers, is that they have even memorized all these word songs. Isn't it reasonable to you to think that that type of a drummer or singer should be, we should get farther down the road with a brief 12-month intervention and moving them toward being socially conversant than a non-drummer, singer, non-socially conversant, similar age matched person? I think so. We think so. Our project team thinks so. Well, unfortunately, that... have you ever heard of such a thing being done before? I hadn't, and I've searched high and low for anything like this. I mean, yeah, there's bilingual instruction, usually for non-English speakers to pick up speaking English. But in this context, no, there's not. Well, you can imagine that things that are that new sort of land with a big thump at NIH in review, and that's what happened to us. But we got some good critical feedback from some folks. We're revising that intervention proposal, and we're going to resubmit that. I agree with those who have said in the past, who have said here at this gathering, and say at many other gatherings too, that we're no strangers to research. Our ancestors were certainly no strangers to research. You don't think that the traditional medicine armamentarium of a traditional healing culture like we have among the Lakota stayed static for hundreds of years. New therapies were introduced. We must have had a way to evaluate whether those new therapies were better than the old therapies. We were familiar with the cosmos, the journey of the stars and constellations through the skies. If any of you have a chance to go to a Lakota Star Knowledge workshop, I highly recommend that you do so. It's fascinating. It's really cool. I mean, it's astounding. So, one of the places we're slowly moving toward is that it's we who are doing this for ourselves. That's where we need to get to. When I sit in our 20-person All Lakota project team around this language revitalization and life promotion project, ironically, I realize I'm the closest thing to an outsider, and in fact, probably along many dimensions, I'm the outsider in our All Lakota project team. But that's the way it was in the past too. I can appreciate that our ancestors gathered together to consider some matter of great importance, some topic, and even though these are all members of the same CRCAIH, I can appreciate that one or a couple more often than not felt kind of like an outsider with his or her viewpoint. So that's the message that I bring to you today, is to give some thought toward changing sort of that tired old deficit-based perspective on our health status and transform it into a strength and asset-based perspective. I've shared just one example. There could be many, many other. Well, it's for you to experience how many other approaches might be able to be developed. But, I feel great every time I roll onto Cheyenne River or Pine Ridge or Rosebud. It just feels great to pass those reservation boundary signs, to see the energy and the beauty of our relatives. So I encourage you to do that also. Pila mai apalo.